Living with chronic neck or back pain is exhausting, especially when a simple, everyday movement triggers a sudden spike of agony. For many patients, standard treatments like physical therapy simply fail to touch it. This comparison shows a limitation of standard medical imaging. An MRI will identify worn cartilage and structural damage, like the degradation seen on the right. But an image alone cannot prove which of those specific areas is actually generating the pain. Pain is not a static object we can photograph. It is an active electrical signal. To locate the source, we have to test the nervous system directly, rather than relying on a snapshot of bone and tissue. Identifying structural damage on a screen is only useful if we can verify that the damaged area is actually the one broadcasting pain signals to the brain. This brings us to a common source of localized back pain, the facet joints, small stabilizing structures along the back of the spine. Attached are the medial branch nerves, highlighted routing upward. Their job is detecting distress and carrying those pain signals to your brain. These nerves are entirely sensory. They do not control muscle movement or help you walk, which makes them a safe target to isolate without affecting your mobility. To address the pain, we first have to prove that these medial branch nerves are the ones actively transmitting the signal. We test this using a medial branch block. It is a targeted diagnostic procedure that acts as a temporary mute button for those specific nerves. Under X-ray guidance, a specialist navigates a needle next to the medial branch nerve at the tested spinal level. Next, they inject numbing medication. The moment fluid coats the nerve, it switches off its ability to send signals. During this process, you remain awake. There is no sedation because the specialist relies on your conscious feedback to evaluate your immediate response. The entire test takes roughly 20 minutes. It requires no incisions, and most patients return home within an hour of the procedure. The numbing effect wears off in just a few hours. This rapid return to normal is a feature of the test. It is a controlled experiment designed to extract data, not to provide a permanent cure. The most critical phase of the test begins after you leave the clinic, during the window when the numbing agent is active. Your task is to attempt the daily movements that normally trigger your pain. Sit, stand, walk, or twist. You track those results in a pain diary. As you test your mobility, you log your discomfort levels and exactly how long the relief lasts. The clinical threshold for a successful block is strict. Your recorded data must show an 80% or greater improvement in your pain. By tracking your movement over those few hours, you transform your subjective experience of suffering into objective medical evidence. If your pain drops significantly after the first test, it can feel redundant to return and repeat the exact same procedure. However, we must rule out the placebo effect, the chance that you felt better simply because you expected to, rather than because of the medication. These charts show why the second test is vital. Running an identical block on a separate day serves as verification. It confirms that the first result was driven by the medication and can be replicated. Repeating the test is safe. The procedure has a low-risk profile, with side effects rarely extending beyond minor, temporary soreness at the site of the injection. Requiring two distinct positive tests provides the evidence needed to justify moving forward with a more permanent intervention. Hitting that 80% relief mark twice means you qualify for the long-term treatment. That treatment is radiofrequency ablation. Instead of temporary medication, a specialist uses targeted heat to disable those verified medial branch nerves, blocking the signal for months at a time. Performing an ablation without these blocks would be guessing. And in spinal medicine, guessing often leads to failed treatments. While a medial branch block does not heal the spine, it provides the diagnostic confirmation required to proceed. It replaces the uncertainty of chronic pain with a confirmed, treatable target.